Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Perelman School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Welcome to ModPath Chat. Today's guest is a very special guest. I know I always say that, but this one is really, really special. Natasha Rekhtman. Dr. Rekhtman and I go back years and years, and she's been part of the tremendous journey in modern pathology. She's one of our very, very busy associate editors, and she is full attending at Memorial Sloan Kettering. That's like equal full professorship. She is also the associate director of the Pulmonary Pathology Service and the Pulmonary Pathology Fellowship at Memorial. Natasha has become quickly very known in the field, many publications and contributions, including heavy involvement with the WHO series on the topic. Today, she's going to discuss with us a recent review article in Modern Pathology around an issue that has extreme importance from a practical point of view. And one would think is easy, but the paper depicts a good practical algorithm to how to tackle the issue of multiple tumors in a lung resection or in a patient, and is that two separate primaries versus not? So thank you for accepting my invitation, Natasha.
George, thank you so much for having me. I really appreciate it, and in particular about having me to discuss this review article. As you mentioned, this is a topic that is has been undergoing a lot of change. And we put in the title the words paradigm shift. And, sometimes we say that, but and there will be minor or major. This is a really major paradigm shift. This is a topic that in the recent years, we have a completely new understanding of, and now kind of how we will incorporate the new knowledge into practice and into staging, into clinical management of patients. All of that will be significantly changing, and depending on how molecular methods are already used in individual practice, that may be already significantly transformed. And for us, having practicing in an institution that has for a number of years routine next generation sequencing, we had this great opportunity to pretty much review our clinical experience. The work that we've done and review that we put together basically reflects what we have learned from our clinical experience with adding molecular methods to routine pathologic assessment of this issue of multiple tumors.
Wonderful. So the issue is how you can assess staging when you have multiple non-small cell lung cancer, and we'll focus on those.
Yeah.
For the reason that will become evident in terms of NGS or what have you. So how common is this to have multiple, and is it now more than before?
Okay, that's a wonderful question to start with. This is in current practice, this issue is extremely common. We looked at the last decade and how frequently our patients who undergo surgery at Memorial have more than one lesion, either synchronous, so at the same time, or metachronous, meaning within a certain period of time. And in our practice currently, approximately 20% of patients have more than one lung carcinoma. That's 1 out of 5. So that's a very common scenario. And so our tumor board in recent years really has been dominated by this issue, because the question is not only the question that we can help with, what is the process? Is this two different tumors in a patient who is a smoker and has risk factors of developing one tumor and subsequently another tumor? Or is this patient who has intrapulmonary metastasis with this unusual process where it's not widely metastatic disease, it's one or two lesions in the lung? Kind of a weird and poorly understood disease, but how to distinguish it? And then after that, how do you manage it? That's a very common scenario, and almost every tumor board that we have a weekly tumor board. We see these patients and we discuss the challenges of how to assess them and how to manage them. So the issue is extremely common. Part of the reason is what changed in practice is that previously, let's say several decades ago, patients presented who were very symptomatic. That's how lung cancer manifested. Now we do low dose CT screening for patients who are smokers, and you detect low stage lesions, or patients in cancer center who are being followed, like patient with renal cell carcinoma, but they're on surveillance for potential downstream metastasis, and you pick up lung nodules. So this is where we're working now is very different from several years ago. Several decades ago. So we're picking up a lot of low stage tumors, and we're picking up a lot of multifocality.
Excellent. So really, of course, I'm cheating a little bit to make it exciting, but I'm really surprised with the 20% figure, because I would have not thought. But again, I don't practice lung pathology every day.
This is a very different figure from what we had even before this low dose CT screening, before such a wide use of CT screening. This is a very different population that we have seen several decades ago.
Excellent.
You would not detect all of these patients with low stage cancers who may not be symptomatic, but if you do imaging, you will detect these lesions.
So, but still, this is, I know, previous decade when I was practicing lung path, we'll look and say, oh, they look the same. It's got to be a met, or they don't look the same. So what is so difficult about it? Tell us. Is there?
Thank you for this question as well. So, looking lung cancers, and so another thing that has changed significantly, even over the few decades, is in the past, we had a lot of squamous cell cancers and small cell cancers in heavy smokers. Where we are now, these are uncommon tumor types. Really, lung cancer is dominated by adenocarcinomas. And this issue of multifocality is very much an issue of multiple adenocarcinomas. And they're very heterogeneous. Lung cancer is not like colon cancer. George, please don't take it personally. Prostate cancer is a very interesting field, but prostate cancer has a much more homogeneous look despite different grades. But lung cancer is very heterogeneous. It's both, in terms of comparing multiple primaries, it gives us some advantage in that we really, in some cases, we can suspect that these tumors look very different. But then there are some challenges, because in some cases, tumors, let's say there is a single tumor that progressed, and then when tumors progress, the histology can progress, so that a tumor that is a recurrence or metastasis can look higher grade than the primary. We know that very well in different settings. Same for lung cancer. And there are other challenges where tumors that we that may look similar, like there is also a look for lung cancer. They have this lipidic pattern. They may look to us somewhat similar. We illustrate a case in the review article that I think to us looks very similar. There are maybe when you go back retrospectively and you start to see, but there are some subtle differences. But looking at the case prospectively, it may be very hard to tell. But then with molecular methods, you can tell that these are, even though there is this apparent similarity, they look very different. They look similar. Molecular profiles are completely different. So when we looked at our experience, so when we started doing routine molecular testing, and we went back and we compared, like using NGS as a gold standard, how do we do with morphologic review when we compare tumors? We do pretty well, but again, over 20%. We have discrepancy where we say we think it's the same or we think it's different, and molecular result is different. So again, it's about 1 out of 5. So for clinical, individual patient management, that's quite significant. So it basically, the answer is there are some, I think what also we were hoping to really learn and contribute from our experiences to really highlight what are the cases that end up being discrepant. Where can we improve? What are those scenarios that we should look out for? So I think this is a learning process. So, and I think certainly with morphology, with this learning experience, we can do better. But there are some cases that are very challenging where you really have to resort to molecular testing.
And when looking at those beautiful images, and I refer the audience and viewers to clearly spend time with the articles. They're beautiful figures illustrating all these permutations, possibilities. Like you just mentioned, tumors may look the same, but they're molecularly different. Hence, that's more likely to be two different primaries versus intrapulmonary mets. Now, on the other hand, it's similar to what in other organs. Just because you're seeing areas of lipidic growth, that doesn't mean, hey, this is a second primary because this has started in situ, if you will, a field effect and popping up with the second primary. So, because these things can happen almost like a recolonization, right? Or a second. It could be a MET and still showing intrapulmonary MET showing some lipidic.
Yeah. So you highlighted one. I think one of the I feel most interesting lessons that we have learned through this experience with molecular, with adding molecular analysis, and that is, we generally think that when you have this lipidic kind of surface growth, the thought was that's in situ process, and that means sort of like in breast cancer, if you see in situ disease and adjacent invasive, that is primary tumor. It's not the case in the lung. You can, and we sort of know that from other, in other ways. We know that pancreas, that's metastatic to the lung. It's a very well, very, very well-known phenomenon. It will colonize the surface of the lung. It will grow over the surface. Excellent. So we know that metastatic tumors can grow over the surface. And we now know that it's the same for lung cancer. If as tumor that is metastatic, that lung cancer that spread from one side to another can grow over the surface and adopt this lipidic pattern. So I think this is an example of a major kind of a point that we learned through this molecular experience that we now can take back to our pathology practice. So if you have a tumor, an adenocarcinoma that has partial lipidic growth, we cannot assume that it's a primary. That's a new primary. So I think that this is something new that we have learned.
Excellent. And the issue of that's well known, morphologic evolution similar to clonal evolution, similar to molecular evolution. So let's switch to the molecular. Okay. I noticed that you're addressing a beautiful diagram there where you're showing if you're doing driver only testing versus a broad panel. Both have. Clearly, the broad panel, if it's available, is always more powerful. But let's focus on the driver-only testing. If you're doing just few genes, it's interesting to see that if you have two, for example, common drivers that are identical, that's still uninformative because these drivers are common. So the likelihood. So you're looking at possibilities versus if you had two uncommon drivers that are the same, then that can help you decide, that must be an intrapulmonary mets because this is so uncommon. It could not be by mere chance. They both primaries went to that uncommon.
Exactly, right? George, exactly. So the same as using our experience to learn about the microscopic features of these multiple tumors. Our approach with this and our goal with this review was to really put together what we can learn from this having broad NGS experience to driver gene only testing. The reason being is that there is different levels of molecular testing access, especially around the world. So we really wanted to learn what is informative and what is not informative. When you have just single gene driver testing, coming from that experience of having a full profiling of tumors, with having the luxury of analyze the tumors with 500 gene NGS panel. So, and this is what we learned. So one very interesting conclusion was that, and it's something that you would anticipate just from playing the odds, certain hotspot driver mutations are common. For example, in smokers, KRAS G12C is common. About more than 20% of smokers have it. So just by chance, a second tumor can have it. So it's sort of what you anticipate, but we actually showed with the data, you can have tumors that by NGS have completely non-overlapping profiles, except for that one common mutation. So that's sort of showing you in actual practice how commonly you encounter that and what the profiles look like. Same for EGFR L858R, the very common mutation in never smokers. Same issue. If you have multiple patients and they have second tumors, just by odds, they may have the exact same mutation. Doesn't mean that this is the same tumor. So this is the kinds of scenarios that alert pathologists if you're working with single gene panels. If you have two tumors, one is with completely different drivers, one is EGFR, let's say the other KRAS, you're done. These are completely different tumors. But there are other scenarios where you have to take things which it may not be so straightforward. This being one of them, where you have two identical common hotspot drivers. This can go either way. This could be the same tumor, or it can be completely unrelated tumors that happen by chance to harbor the same mutation. So I think this is an example of a lesson learned, and something that pathologists can apply in practice if you have a single gene or small gene panel testing, and some of the results are fully informative. For example, again, if you have two different driver mutations, this is done, and this is fully informative. But there are certain scenarios, for example, a scenario where there is no driver in either tumor, which can happen in about 15% of patients. You will get that result, that both tumors have nothing. And then those are the scenarios where either, what do you do in that case? Again, either if you have access, the ideal situation would be to get NGS testing, and otherwise just to do the best with the information that have pathologic information and clinical information. And we, again, through our experience, we provided some additional parameters for pathologists to take into account to hopefully, even without NGS, to arrive at more accurate and most accurate interpretation.
Excellent. And of course, if you have NGS, and again, here's if one is showing mutations A, B, C, D, and the other is E, F, G, H, that's obvious. These are two separate primary. But it still could be two separate primaries, like you said. If it's a common driver A and common driver A, but then B, C, D, and F, G, H mutation in each one, that's still telling you, despite that they shared that common driver, just because it's common, you look at the rest of the mutations. So the more you have in these numbers of mutations you're looking at, and here's an NGS panel, that empowers you to make that distinction. Otherwise, it would have been uninformative if you're just looking at one driver.
Exactly.
And then the part about the intrapulmonary mets, you want to comment on that? Truncating mutations and how you can have evolution, and you have to be careful with that too, right?
Exactly. The good thing, I guess the advantage of lung cancer biology and how it really helps us with interpreting multiple primaries is that the majority of mutations in lung cancer are truncal. So if you look at the evolution and the tumors and the studies that looked at clonal evolution, multi-region sequencing in lung cancer, which there's been fabulous study done. They have, in contrast, for example, to renal cell carcinomas, right, which are not a single trunk. which are multiple trunks. Lung cancer is really dominated by truncal mutations, whereas branch mutations are much less common. And this really helps in applying molecular testing to multiple tumor comparison in a single patient.
Because the truncal will still appear.
So you may, right. So we do commonly, and we illustrate that in one of the figures in the article, that you may have a single acquired mutation. So some mutations that will be different in tumor 1 and tumor 2, yet with the majority of mutations taking into account for example, the other mutations being identical. That confirms that these are clonal tumors. So the fact that there are some acquired mutations which are frequently subclonal, that really does not make interpretation particularly challenging.
Right, and that's the example you mentioned. They were like it was asynchronous 4 years apart, one in the right lobe and one right lower lobe versus second one was in right middle lobe 4 years later, and they share several of the truncal, and then there were a couple clonal evolutions.
Yeah, absolutely.
You still interpreted that as intrapulmonary mets of the original tumor. Which brings us, we'll finish with what you recommend practically, but just I wanted to, the difference is significant. If you make that mistake, is significant in terms of management. I mean, the obvious thing is staging, clearly, but
staging is different. George, I think the clinical implications will also undergo, and management will all undergo paradigm shift together with our increased accuracy of separating these processes. Because I think it's very hard to even interpret past literature where there is, at least 20% and likely more discrepancy in how we're classifying these processes, right? So when you're looking for patient outcome and when you have such significant misassignment of patients, I think this will be really a new, the new data will have a whole other level of accuracy in terms of patient management. Certainly in terms of in terms of managing patients with, let's say, so we're dealing with very particular subset of metastatic patients. These intrapulmonary metastases that are not patients with widely metastatic disease, that's usually not a challenge. We know that the patient has wide metastasis and few lesions in the lung, that's more likely metastasis. It's oligometastatic lesions. So it's patient who has 1 or 2 additional nodules that have spread through the lung. And the management of these patients is also undergoing change, particularly as we're better able to identify them. I think these are biologically very different processes. So I think it's very important that we identify them accurately. And so with all these new information and methods, I think we're definitely at a very different position right now. And I think this will inform how these patients, much better, how these patients should be managed.
So yeah, that's a very important point to emphasize. Then we're talking about oligo, about early metastasis within the lung, and now if we start refining the data, we're gonna hopefully the management of this and the outcome is gonna evolve in a more informed fashion, because you cannot rely on the old literature, because we were not so aware of the issues that we just discussed today.
Absolutely.
And that's why I think
the AJCC, the last staging edition, so we were the 8th edition, and it's over a decade ago. So, and all this new information has accumulated since the last AJCC. So, of course, the new edition will incorporate all the new knowledge, and then it will take still a period of time for clinical data to accumulate. But I think it's all coming. We're all set. This sets the stage for the much better clinical understanding of this disease and how to manage it.
Extremely important. So let's finish then with the take-home message. So what do you do now? How do you approach? You have a lung with a couple of nodules, let's say synchronously. What is your practical recommendation for our audience? How do you approach?
George, we always, in our report, we offer our pathologic assessment. But and there are different levels of confidence that we have. So we use that judgment, and particularly with the knowledge that we gained about what things can kind of can give us mislead us. What can be misleading? So we will do, and in our practice, all resected tumors do undergo molecular testing. So we always also revisit if there is a discrepancy. We amend. So we do stage. We do still stage based on our pathologic assessment at the time that we're reviewing the case. But based on morphology, based on our best assessment on morphology, even knowing that some cases are challenging and that molecular may overturn it. Currently this is one of the points we raise in the review. Currently, we issue staging based on our pathologic assessment, even though it is clear that molecular testing will overturn it in a certain number of cases, and even though in some cases we may not be certain, and we're aware of it, that we're not certain. So the question we posed is, should we change this? Should we actually defer staging? Should we defer staging if molecular testing is being done, actually wait until we have full information and issue staging based on the full information that we have that would be most accurate? It was, we wanted to open that for discussion. This is a little bit unprecedented in the staging, but that's the new reality of it. So we just wanted to bring up that point as a consideration, as a possibility. Another thing I wanted to mention I think it also, what this work brings up is we really need a much closer collaboration between surgical pathologists and molecular pathologists. In some of these interpretations are fairly straightforward. I'm a surgical pathologist. I don't have a molecular pathology degree, but we have very close collaboration with our molecular pathologists. So many of these cases are straightforward. Some of them we will get in touch with our molecular pathologists and have them review, and especially if there are some low tumor content, various issues. In our practice, we sequence normal blood. Things get very complicated if the tumors are sequenced unmatched. Correct. So there is like normal blood, normal variants within the tumor. It gets complicated. So another thing we highlighted, mentioned as a conclusion, is that doing this assessment is kind of a collaborative effort. And it calls for, kind of input, a new level of input between surgical pathologists and molecular pathologists to arrive at the final interpretation.
And all these are probably the best venues, the molecular tumor board or the tumor board where you're discussing.
Oh, absolutely. Absolutely. And then bringing it back to the molecular tumor board, clinical tumor board, putting this all together with clinical information and discussing the management steps.
So you start by morphology, you do your best judgment by morphology, the ones that are potential traps, pitfalls, you admit that, and then when the molecular comes, you issue addendum and you may correct the staging. And Correct. You put forward in this review a beautiful flowchart in Figure 7 on suggesting how to do that. And this is a wonderful contribution, I must say this is a review, and there were a lot of articles you cite, and you and I working together. This is a very active topic, and people submitting studies on that. So I'm glad to see that it's finally moving forward to more practical view. Thank you, Natasha.
Thank you.
Even a prostate pathologist learned something. So
well,
you don't need to bring us down. That prostate is simple. Come on,
No, it was not meant like that at all.
Yeah, just because it affects men only, it's still an important disease,
Very important, absolutely.
Okay. All right.
Well, it was a real pleasure to discuss this with you, and thank you for highlighting this very important topic for your listeners. And it was a real pleasure to join you today.
I'm sure we'll see you again on this.
Look forward to it.
Ciao.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.